So the next drug that we will be discussing about is Vanco. Again, another anticipated discussion of therapeutic role or lack of therapeutic role of Vanco in PSC. Our first speaker is Dr. Yanka Davies. She is a pediatric gastroenterologist and hepatologist, also an associate professor of medicine and hepatology at Stanford. I think you have training in pediatric GI nutrition and hepatology, particularly particular interest in PSC, and she has done some work under Dr. Cox at Stanford.
All right, thank you very much. Thanks for having me speak on oral vancomycin. I will be talking about the pros of oral vancomycin and a little bit about my experience on oral vancomycin. And so just briefly, it is a glycopeptide antibiotic that's targeted against gram-positive bacteria. It targets in the colon. It's commonly used to treat C. diff, and it's still used for treat C. diff, and it's not absorbed by the gut. So this is the first case study that was actually vancomycin was used in. This was Dr. Cox's patient. This is 25 years ago. He discovered a 15-year-old boy who had PSC IBD, presented with diarrhea, rectal bleeding. Stool studies showed C. diff. And at that point, he opted to use vancomycin to treat his C. diff, which isn't actually first line. Typically, people use oral flagyl to treat. His liver numbers got better, his rectal bleeding went away, the diarrhea got better, and he seemed to do well. After the 10-day course of oral vancomycin, his symptoms came back. The diarrhea was there, the rectal bleeding was there, and his liver numbers went back up. I always say this is the aha moment that is really saved so many kids that I've taken care of. So he rechecked the stool studies at that time. There was no C. diff in the stools. Put him back on vancomycin, and the liver numbers went back to normal. His diarrhea resolved, and the rectal bleeding resolved. And to this day, 25 years later, that patient remains on oral vancomycin. So the treatment regimen that we use on oral vancomycin is typically 50 milligrams per kilogram per day, about 500 milligrams 3 times a day. It is, for us, a long-term therapy. We haven't been able to take patients off the oral vancomycin. If they do come off or inadvertently get onto it, and I'll talk about this, a different brand of vancomycin, the symptoms come back. So their itching, their diarrhea, their abdominal pain all seem to return. There is a big difference, and I think this is why there's so much debate on oral vancomycin. We have found that there are only 2 brands that work. It's either Ani or Ani's generic. We've had multiple patients come in on Acorn or other brands and haven't responded. We just got data back this week. We're actually working with a lab at Stanford that looked at all the generic brands to look at the differences, and there clearly is a difference between what's out there generically, as well as what's out there for brand and Ani. Hoping to publish that soon. So it tends to work for us in early stage disease. And remember, I'm a pediatric gastroenterologist, so a lot of times these kids do come to me with early disease. And that could be some of the difference that we see in the adult population. This was one of our first studies that we published. This is before and after with ALT and GGT numbers, before and after vancomycin, 1 to 2 months after starting. Not only did the liver numbers get better, but clinically the patients improved. All the symptoms that they had prior to the start of vancomycin improved. Again, this is another study over 8 to 12 months showing a decrease in ALT and GGT on these patients. So what are the symptoms? I'll just briefly go over this. It's obviously the itching, the fatigue, the diarrhea, the weight loss. We've seen no common related adverse events reported. It does, vancomycin, and I think this is where we see a lot of concern about, it does select for VRE, but we haven't seen one documented case. And again, the oldest patient is now, has been on vancomycin for 25 years. So Dr. Bolles had mentioned earlier that it needs to matter. It's not just changing the liver numbers. It's clinically making a patient better. It's getting them back to functioning. And so we just put out an article looking at 13 patients before and after vancomycin of their liver histology. And we blinded the pathologist. So we didn't let the pathologist know this was before or after. And the patients showed an improvement of reduced inflammation before and after vancomycin, not only on those patients, but in the liver, but also in their colons, a complete improvement in their disease. I recently treated a patient from Kaiser, an adult patient, and I got a call from the gastroenterologist and worked with him. And he said, the patient's off of his immunosuppressant. And I said, yes. And he said, he's only on vancomycin. And I said, yes. And he said, so I just rescoped him and everything's normal. What is this? And this is exactly what we've seen in all of our patients. Before and after our patients' liver histology has improved. Their disease and their colons are under control, if not better. They've changed from either, this study from 7, changed from chronic active colitis to unremarkable disease. 4 had no change and no progression of disease. So what are our next steps on looking at this? Really dosing is 500 milligrams 3 times a day, the right dose. We do know that there are some patients that are able to come down on their dosing and still maintain. We haven't looked at those patients for histology yet. The patients I just showed you on before and after on their liver biopsies, those patients were all on 500 milligrams 3 times a day. How long do you need to take vancomycin? All my patients are still on it. I have many patients in this room right now, thanks you guys for coming in, that are all still on vancomycin. How do we monitor these patients? We'd still continue to suggest doing repeat liver biopsies as well as colonoscopies. Is it different between adult versus pediatric patients? So we're currently now working with Open Biome, looking at what we've collected is before, stool studies before actually treating with vancomycin. And that data we actually also just got back this week showing that there is a difference in that flora prior to, as many studies have shown. And what we'd like to do is now do fecal transplants in these patients, targeting the deficiencies that we see in the patients that we've collected over the years. And hopefully we'll do that with Open Biome and Finch Therapeutics. So that's what's on the road. Thanks, you guys.
So the next speaker is Dr. James Tabibian. So you've done a study showing that there is a benefit of Vanco in PSC. You're arguing that it may not be helpful. He is associate professor of medicine at UCLA and also a director of residence research training. James has significant contribution to the field of cholangiopathies, and he's also interested in the relationship between the microbiome and the immune system and how that is related to possibly initiating or contribution to the progression of liver diseases, particularly PSC. So James, I will leave the stage to you.
Okay, well, good morning again. And I must say I'm glad that I went after our first 3 speakers on the Counterpoint, because I think they really eloquently outlined what are the principles that we should be keeping in mind when thinking about a chronic, generally slowly progressive disease and a treatment for it. So all the groundwork I feel like has been laid out for me, and my job is going to be somewhat easier as a result. Let's get started. So my objectives, or our objectives, are to review the cons and the areas of uncertainty regarding vancomycin or Vanco. And I group these into 3 main levels. I think that at a drug level, at a patient level, and at a public health or other or miscellaneous level. And we should recognize also that many of these areas of uncertainty tend to cross over. And also, I'll just point out a couple of potential future directions in vancomycin or Vanco research. So, at a drug level, what are the concerns? So, first question that comes to mind is what dose? How many milligrams? How many times per day? Should it be every day, every other day? What's the minimum dose that we can use that will be effective? I think another question that comes to mind is, okay, let's say we started and things are going well. Can this medication be stopped? Similar question comes up in many, many other diseases, including, but not limited to, inflammatory bowel disease. Someone is on 6-mercaptopurine or Remicade or infliximab, and they're doing okay for a few years, and the patient will ask us, hey, do you think I can finally come off this medicine? It's an immunosuppressant. It can have all kinds of adverse effects. I'm really doing well. I would rather not come in every 8 weeks to get an infusion or inject myself every 2 weeks. So it's a very, very valid question. And if it can be stopped, I guess the question is, after how long? Is it once I'm feeling better, maybe keep going for another 6 months and then stop it? Should it not be stopped? Or does it not matter how I'm feeling? We kind of go based on labs, and once the labs normalize, that's a sign that, okay, maybe in a few months or in a year or two, I can stop the medication. I think we don't definitively know. And then I think related to that is, so what exactly is the treatment endpoint or the biomarker that we should follow? And I think Dr. Bolus and others have nicely pointed out that in PSC, alkaline phosphatase and other labs, it's a little bit tricky to interpret what they mean. So just because labs improve doesn't necessarily mean that the major endpoints, for example, developing cirrhosis, developing varices, cholangiocarcinoma, doesn't mean that those are being prevented. And the arrhythmia post-heart attack analogy is an excellent one, as is, for example, lowering cholesterol levels with certain medications, like Zetia, for example, ezetimibe, doesn't seem to necessarily prevent heart attacks. So it's true, the cholesterol levels do get better, but that doesn't necessarily mean that surrogate biomarker is a direct correlate to major clinical endpoints such as heart attacks or strokes. So that being said, what biomarker should we follow? I think alkaline phosphatase is perhaps the best biochemical or serum marker to follow. Do we follow patient-reported outcomes or PROs instead? So, for example, if you're starting vancomycin because your labs maybe aren't terribly high, your bilirubin or alkaline phosphatase, but you have a lot of itching, is that going to be what we're going to follow? If the itching improves, it means you're a responder. How about if your labs don't improve, but your itching does, or labs worsen? What do you do in that scenario? I think we're really, maybe most of us at least, are not certain. Or do we follow MRCP findings? We say, you know what, we're really happy that the labs are better, but we know that might not be enough. We're relieved that the symptoms are better, but how about the imaging progression? If we see that year after year you're having more scarring, more strictures, your liver stiffness goes up, what really are we gaining? It's tough to know. So as far as at a patient level, let's say we decide, you know what, vancomycin is the way to go, we should use this drug, period. Okay, well, which patients should we use it in? And I think these are really clinical challenges that some of us don't know the answers to. In fact, I'd say many or most of us don't know the answers to. So do we try this in all patients? Even if you're doing well, no symptoms, alkaline phosphatase is 85, perfect, bilirubin's normal, no symptoms, you didn't even know you have PSC. It only just became apparent because you got an MRI for something else, and lo and behold, it looks like you have PSC. Should you be on vancomycin, or is it or do the risks outweigh the benefits? So maybe only patients who have symptoms of PSC, maybe right upper quadrant pain, maybe itching, maybe fatigue, and will it even help the fatigue or the pain? I think it's unclear. Maybe we should treat people who have, or patients who have biochemical abnormalities consistent with active, if you will, PSC, as opposed to more quiescent or clinically inapparent disease. And should we use it in patients who have cirrhosis? The analogy was made, or it was mentioned earlier by our URSO speakers that maybe ursodiol doesn't really work that well once you have cirrhosis, especially if it's advanced cirrhosis. So starting it late in the disease process probably doesn't make a whole lot of sense, or at least won't be very effective. Is that the same with vancomycin? Or will vanco work at any stage of disease? Maybe it works by a completely separate mechanism. Doesn't matter what stage you have, it will halt disease progression. We don't know. And then let's say you're on vanco. You start vanco, you started at a dose that your provider suggests is the way to go, but there's no benefit after 3 months. Do you stop the medication? Do you keep going? How do you know it's working? Obviously, if you're feeling much better, your labs are improving or normalizing, that's probably a good indicator that something's happening, and it's something that's therapeutic, but will it make a difference in the long run? And one of the big challenges with PSC, aside from it being a rare disease, is that it takes so long for so many patients to really develop a major complication, such as variceal hemorrhage or cholangiocarcinoma or cirrhosis or need for transplant. Some unfortunately develop it much earlier in the course, but because it's such a heterogeneous disease, it's tough to design clinical trials to effectively and definitively answer some of these questions that we have. And then I think a false sense of well-being based on biochemistries is something that is relevant for the patient as well as the provider. So if your labs are improved, does this really mean that you're protected against long-term adverse outcomes or complications? Remember that the longest clinical trial of vancomycin, as far as I know, at least in adults, is 3 months. I actually came across very recently a triple-blinded randomized controlled trial of vancomycin in adults. I was very amazed to find out that it was completely conducted in Iran. I didn't know that Iran had a real PSC patient cohort or investigators interested in the disorder. And it showed promising results similar to our study with vancomycin in adults based out of Rochester, Minnesota. But again, the follow-up was 3 months. We don't know after that what happened. What do you do with vancomycin? So a lot of questions that remain unanswered. Some other miscellaneous concerns. So selecting for a resistant bacterial organism, I think that's certainly something that's at least theoretically possible, and certainly with in other disease settings and other antibiotics, that is a reality. And so that can affect not only the patient, but the people around the patient, who the patient comes into contact with, as well as ultimately on a societal level, it would become an issue. Just like, for example, multi-drug resistant organisms like TB, tuberculosis organisms, or staphylococcus infections like MRSA, VRSA, and so forth. I think cost or insurance coverage is also a concern. So if your insurance covers it, you could say to yourself, okay, great, I don't have to pay out of pocket. If your insurance doesn't cover it because it's an off-label indication, it's an expensive medication. A lot of you might know about a 10-day course of vancomycin, for example, for C. diff, which is typically covered by insurance, is almost $1,000. So we're talking a lot of money. That's about a week's worth is $1,000. So a month's worth maybe is $3,000 to $4,000. That adds up at the end of the year. And then even if your insurance covers it, one might say, okay, insurance is covering it. That means insurance is paying more. That means the increased cost to the insurance company is now going to be spread around all of the folks it covers. So everyone's premium is going to go up. It's going to go up because they're paying for vancomycin, which is a drug that we're not even certain who it works in and how well it works. So is it fair to the healthcare system, to your cousins who, let's say, or your friends or your relatives who don't have PSC, that if insurance covers meds or procedures that might not have a clear indication or may not be clearly indicated? It's maybe more of a philosophical or public health discussion. And then I think there are some provider issues too. So finding a provider who's willing to prescribe vancomycin and then follow you thereafter, not just say, yeah, I can write a prescription. I mean, you could probably order it online and you don't even need to find a provider, but to do it right can be challenging. And then what exactly does biochemical improvement mean long term? So I think if you are a provider who is going to prescribe this, or let's say you find someone who will prescribe it for you, maybe your PCP will do it. I think, as Inka was mentioning earlier, you probably shouldn't let your guard down. Keep surveilling, keep monitoring. You shouldn't just say, oh, I'm on vancomycin, I'm doing great. No need for colonoscopies or imaging here and after. I think until we understand better how vanco affects folks long term, we should just keep up kind of the standard of practice as far as surveillance and monitoring. I think there's also a medical legal consideration here that many people feel, or providers feel, uncomfortable about. So let's say out of the kindness of your heart, you want to prescribe vancomycin just to, give it a shot. Maybe it'll work. But then something bad happens. The patient develops some kind of infection, some severe rash that scalds their skin. Then what ground does that physician or provider, PA or NP, have to stand on? It's a tough situation, and it's one that's realistic. And then I think with all this being said, is Vanco really ready for prime time? Minocycline, another antibiotic, also showed a lot of biochemical improvements, and that was a 1-year-long study. Metronidazole has also in some studies shown improvement in Mayo risk score and bilirubin, including in our study, in fact. And so has tetracycline, going many years back. So what is so special about Vanco that would make us think that we should go ahead and start prescribing it? Or should we just say, look, it's very promising, let's continue our research to find how it works, who it works best in, and how long we should be taking it for and at what dose. So areas for future research, I think we really need more mechanistic insights on how vancomycin impacts PSC and the microbiome in general, as well as in PSC. And I think there are a few ways to do this, and that includes cell culture systems, animal model systems, and then I think more randomized clinical trials are needed. I think case series and prospective studies are great. I think if we can maybe step up the level of evidence to a randomized control trial, that will hopefully give us the data that we need and the evidence that we need that would enable us to make more confident recommendations for our patients' health and well-being. So I think in summary, vancomycin has promising experience and data thus far, but there are many outstanding unknowns. The unknowns are on a variety of levels. There are some potential consequences, particularly long-term, that I feel are uncertain and understudied. And certainly further research is encouraged. I think it's needed and warranted to determine if Vanco is safe and effective and also life-prolonging. And if so, what would be the optimal target population and regimen? Thank you.